Cultural humility and responsiveness in HIV service delivery. We want to acknowledge that originally this was going to be a webinar with our partners, AIDS United, who are the experts in cultural humility. Unfortunately, due to technical difficulties, they will not be able to co-facilitate with us today or present. We're hoping that we will be able to work together and provide a webinar in the near future, and hopefully have a series related to cultural humility and cultural responsiveness in service delivery. I want to take the time now to introduce my colleague, Zina.
Good afternoon. My name is Zina Hazuri, and I'm a Capacity Building Specialist here at the Latino Commission on AIDS.
And my name is Gabriela Betancourt. I am also a Capacity Building Specialist here at the Latino Commission on AIDS for our program Hands United, and I also work as the Deputy Director of Research and Evaluation for the Commission. So just to give you an overview of what we're going to be doing during the webinar, we will be discussing frameworks of cultural competency and cultural responsiveness in HIV service delivery. Race, ethnicity, gender identity, sexual orientation, socioeconomic status, and many other societal factors are associated with HIV risk, treatment adherence, and access to prevention. Today we're going to be exploring ways to successfully incorporate culturally competent and culturally responsive strategies in HIV service delivery for our priority populations to attain health equity and reduce disparities in our communities together. But first, just to give you a little background on who we, as Hands United, who we are. We provide CBA, Capacity Building Assistance Services, under 3 components funded by the CDC: high-impact testing, prevention with HIV-positive persons, and organizational development and management. Under high-impact testing, we offer a range of services including stigma mapping, targeted testing, recruitment and retention, social marketing, social network strategy, and much more. Under prevention with HIV-positive persons, we offer cultural humility and responsiveness. We address stigma, linkage and retention and care, CLEAR, and much more. And under organizational development and management, we offer understanding and managing burnout, strategic planning, board development, grant writing, and much more. As Hands United, we follow our 5 values, which include sex positivity, multiculturalism, innovation, critical thinking, and health equity throughout all of our CBA services. Just to give you a little background on the Latino Commission on AIDS, our organization, the Commission is a nonprofit organization founded in 1990 to fight HIV/AIDS in at-risk communities nationwide. The Commission provides services in more than 40 states, as well as Puerto Rico and the Virgin Islands. We have demonstrated a long history of building local, regional, and national coalitions. The Commission's public health model encompasses 5 core and complementary services that include behavioral research, HIV prevention and health promotion, capacity building assistance, CBA, of which Hands United is one of our CBA programs, HIV testing and access to care, as well as health policy, advocacy, and community mobilization. And now for our first section of the webinar, we're going to discuss the Cultural Competency Continuum. And for this first section, I'm going to turn it over to Zina. First, let's go over the objectives. The objectives of this first section of the webinar is to explore the stages of the Cultural Competency Continuum and discuss tips to integrate and implement cultural competency strategies.
The definition of culture refers to integrated patterns of human behavior that include the language, thoughts, communications, actions, customs, beliefs, values, and institutions of racial, ethnic, religious, and social groups. The definition of competence implies having the capacity to function effectively as an individual and an organization within the context of the cultural beliefs, behaviors, and needs presented by consumers and their communities. Therefore, cultural competency is a set of congruent behaviors, attitudes, and policies that come together in a system, agency, or among professionals that enables effective work in cross-cultural situations. Now we're going to take a look at the cultural competency continuum. Cultural competence is a complex framework, and there is a tendency for systems and organizations to want a textbook solution, a quick fix, a recipe, or a how-to, or a step-by-step approach to being competent with regards to specific cultures. The complexity of achieving cultural competence does not allow for such an easy solution. The CROSS framework emphasizes that the process of achieving cultural competency occurs along the continuum and sets forth 6 stages, including cultural destructiveness, cultural incapacity, cultural blindness, cultural pre-competence, cultural competence, and cultural proficiency. It is helpful for systems and organizations to conduct a self-assessment and use the results to set goals and plan for meaningful growth. The National Center for Cultural Competence developed the following system or organizational characteristics that may be inhabited at various stages of the cultural competence continuum. The characteristics are delineated in this continuum and are not meant to define a system or organization. Rather, they allow systems and organizations to broadly gauge where they are and plan for positive movement and growth to achieve cultural competence and cultural proficiency. The continuum is dynamic and not intended to be viewed in a linear manner. Systems and organizations may be at different stages at different times with different priority populations and cultural groups. Finally, system and organizational capacity is not limited to the arrival at cultural competence or proficiency, as there is always room for continued growth. So let's take a look at the first one here. Cultural destructiveness is characterized by attitudes, policies, structures, and practices within a system or organization that's destructive to a cultural group. This stage on the continuum acknowledges only one way of being and purposefully denies any other cultural approach. It's also the most negative end of the continuum, represented by attitudes, policies, and practices that are destructive to cultures and consequently to the individuals within these cultures. One of the examples that you'll see here is ethnic cleansing. Historically, some agencies have been actively involved in services that have denied people of color to access their natural helpers or healers, removed children of color from their families based on race, or purposely risked the well-being of minority individuals in social or medical experiments without their knowledge or consent. What are some of the other examples of cultural destructiveness that you know? You can use the chat function to give us some responses. So some of the examples are what happened with the Nazis in Germany, genocide or ethnic cleansing, as we gave the example on the slide, non-consensual sterilization of women, violence or bans against trans women in female-identified bathrooms, the war on drugs, exclusion laws, and avoiding certain curriculum topics. The second stage of the continuum is cultural incapacity. Cultural incapacity is the lack of responding effectively to the needs, interests, and preferences of culturally and linguistically diverse groups based on biases. Cultural incapacity is the lack of responding effectively to the needs, interests, and preferences of individuals based on their culture, language, race, sexual orientation, religion, socioeconomic status, country of origin or nationality, or other groups based on extremely biased views toward those outside of a culture other than your own. A system or an agency does not intentionally seek to be culturally destructive, but rather lacks the capacity to help minority clients or communities. One of the examples given here is institutional or systematic bias. Or within an agency, it can be seen in discrimination in hiring and promotion practices. It can also look like not providing bilingual personnel when needed, disappropriate allocation of resources that may benefit one cultural group over another, subtle messages that some cultural groups are neither valued nor welcomed, lower expectations for some cultural, ethnic, or racial groups. The third stage of the continuum is cultural blindness. It is important to note that this stage may be difficult to grasp for some people because most people believe that they are very culturally competent. But these individuals might instead be within this stage of the continuum and not know it. Cultural blindness is an expressed philosophy of viewing and treating people as the same while ignoring differences. An example of cultural blindness is the equality versus equity debate. Equity is giving everyone what they need to be successful, while equality gives everyone the same thing regardless of their need. Equality aims to promote fairness, but it can only work if everyone starts at the same place and needs the same help. The following are examples of cultural blindness. Workforce that lacks diversity. An institution that does not attend to persons with disability in office buildings. For example, the lack of a ramp to accommodate persons with wheelchairs. Another example is approaches in delivery of services that ignore cultural strengths. Ethnocentric approach to services. For example, implementing an intervention that has not been proven effective for African American populations but has worked well with other racial ethnic groups. Another example would be attitudes that blame consumers, individuals, or families for their circumstances. For example, All Lives Matter as a response to the Black Lives Matter movement represents cultural blindness because it ignores the challenges that Black communities face and might blame Black individuals for their circumstances. Another example could be someone saying, "When I see children with disabilities, I do not see their disability. I only see children." The fourth stage of the continuum is cultural pre-competence. This is a level of awareness within systems or organizations of their strengths and areas for growth to respond effectively to culturally and linguistically diverse populations. The following are examples of cultural pre-competence. An organization can make the agency more welcoming with pictures, magazines, and music that reflects the cultures of the community served. This also includes using signage that allows clients to choose which bathroom they want to use, regardless of their gender. Another example includes hiring practices that support a diverse workforce. For example, a diverse staff that reflects the diversity of the people served by the organization. A third example, addressing consumer complaints about culturally insensitive comments and or services is also cultural pre-competence. The fifth stage of the continuum is cultural competence. Cultural competence is a demonstration of acceptance and respect for all cultural differences. This is shown in an organization's ability to integrate principles of community engagement that results in the reciprocal transfer of knowledge and skills between all consumers, collaborators, partners, and key stakeholders. The following are examples of cultural competence. A mission statement that articulates principles and values for cultural and linguistic competence in all aspects of the organization. Specific policies and procedures that integrate cultural and linguistic competence in each core function of the organization. The ability to use and or adopt evidence-based practices that are culturally and linguistically competent. The maintenance of a diverse and culturally and linguistically competent workforce, and ongoing education for self and others. The last stage of the continuum is cultural proficiency. Cultural proficiency within a system or organization is the ability to hold culture in high esteem while using it as foundation to guide all their endeavors. Organizations seek to add to knowledge learned from cultural competency practice by conducting research, influencing approaches to care, and improving relationships with diverse groups. The following are examples of cultural proficiency. Develop and disseminate health and mental health promotion materials that are adapted for specific cultural groups. For example, the CLEAR intervention was adopted to suit HIV-negative persons and having bilingual literature for agencies that serve those whose primary language is not English. Another example, actively pursuing resource development to meet the intended priority population. An example would be differentiating the needs of all learners. Continually enhancing and expanding the organization's capacity and culturally and linguistic competence. And advocating alongside and on behalf of populations who are traditionally underserved. Establish and maintain partnerships with diverse constituency groups which span the boundaries of traditional health and mental health care, and eliminate racial and ethnic disparities in health and mental health.
Great, thank you, Zena. So now we want to unpack the continuum a little bit, because there's sort of an expectation of personal change and transformation with cultural proficiency, an alliance with groups other than one's own, and a lifelong self-assessment and reflection. And we wanted to present and discuss another model that is useful, and one is the cultural responsiveness model. So a bit of a background on moving towards cultural responsiveness. In this section of the webinar, we are going to hopefully increase our cultural responsiveness by developing strategies that adhere to the different levels of multiculturalism within our own communities, using a cultural responsiveness framework that acknowledges the continuous process of active learning and openness to other cultures. We will begin learning and thinking about the development of strategies and methods to enhance our organization's abilities to effectively meet the needs of communities disproportionately affected by HIV. First, let's take a look at defining culture. So culture defined. The definition of culture refers to integrated patterns of human behavior that include the language, thoughts, communications, actions, customs, beliefs, values, and institutions of racial, ethnic, religious, or social groups. Now, we understand that an individual or community members have a culture, but organizations have unique cultures too. To address human resource and organizational need assessments and capacity building planning to apply to A, cultural humility, which focuses on the individual staff level or interpersonal dynamics, and B, cultural responsiveness, which is focused on the organizational level or system dynamics to provide HIV health and support service delivery. We can think of organizational culture, which is the circle on the left in red, as leadership, values, competencies, policies, processes, procedures, and staff perceptions, beliefs, and attitudes. Where we can also see that on the right, in the blue circle, we can see the collective and individual culture from a population served, such as thinking about the needs of second-generation Latino HIV-positive heterosexual men and their unique needs, the unique needs of African-American women, the unique needs of black men who have sex with men, or MSM that also includes Latinos, so Afro-Latinos, and similarly we can think of for transgender women. In order to move towards becoming a culturally responsive organization and service provider, we need to think about the three provider domains. As the arrow suggests, the domains function together in an ongoing and continuous process, like gears in a clock. There is no set point where one domain ends and another begins. Looking at the first cog on the lower left, competence, we can define that as a set of congruent behaviors, attitudes, and policies that come together in a system, agency, or among professionals that enables an effective work environment in cross-cultural situations. Moving up towards the cog at the top, humility is defined as a lifelong commitment to self-evaluation and self-critique. It revisits power imbalances in the client-provider dynamic, interpersonal dynamics. The lower cog on the right is responsiveness, and that can be defined as targets the services provided to the client at various levels of the organization, at the staff level, at the programmatic level, at the administrative level, etc. So let's look at this dynamic process from a different perspective. Again, going back, as the arrow suggests, these domains function together in an ongoing and continuous process. There's no one point where one domain ends and another begins. Being an organization that is culturally competent, whose staff exercise cultural humility and provide services in a culturally responsive way to meet the needs of the population served, requires an ongoing dynamic process. It is not static. These provider domains constantly inform each other and shape service delivery. Our next slide provides a culturally responsive framework that was developed by SAMHSA. The distinction of the two concepts is both critical and complementary for the work of CBOs. Where cultural humility centers itself on the lifelong process of growth and learning, self-evaluation, and self-critique to address power imbalances between the provider and the client, cultural responsiveness centers itself on the capacity of an organization or a system to respond with patient-centered care, keeping in account varied social and cultural factors experienced by constituents that may affect, either negatively or positively or both, engagement in care. This three-dimensional model above, as mentioned earlier, developed by SAMHSA, provides us with an applicable framework. Along the x-axis, we see the core elements of competency: awareness, knowledge of behavioral health, and skill development. And along the y-axis, we see the foci of culturally responsive services at varying levels: the individual, the programmatic, and organizational. The volume of the entire cube represents the interactions of these according to an infinite number of characteristics of the populations we seek to engage. In this particular model, we see some of these defined as African and Black Americans, Asian Americans, Hispanics and Latinos, Native Americans, gender orientation, sexual orientation, drug culture or substance use culture. These factors are infinite. So this is yet another example of how the responsiveness framework can be applicable to our work. We can consider Blankenship's 3 A's: availability, accessibility, and acceptability, all needed for a successful and effective structural intervention. We can relate availability to cultural competence. Accessibility to cultural humility, and acceptability to cultural responsiveness. In other words, what makes your services available to your consumers? Think about this question at the individual level, at the programmatic level, and at the organizational level. What makes your services accessible to your consumers? Think about that question at the individual level, at the programmatic level, and at the organizational level. And then let's think about what makes your services acceptable to your consumer, i.e. responsive to the needs of your consumer. Think about that question at the individual level, then at the program level, and then at the organization level. So now that we've reviewed quite a bit of content, we want to give you all a chance to ask some questions. So what questions do you have? Please either unmute your phone or feel free to use the chat box. We'll give you all a couple of moments to see if there are any questions. Hello. So we have a question that came in from, excuse me if I'm saying your name incorrectly, Tashuna Albritton. And the question is, how does an organization measure their achievement of reaching cultural humility? I'm wondering if anyone that's presenting might have a response or an answer or a thought about that. If that's the case, feel free to raise your hand. Or type in a response in the chat box. In my understanding of cultural humility, there are a number of measures that can be used. Some of these include qualitative measures. Some of these can include quantitative measures, surveys. Again, moving forward in our series, our partners, AIDS United, are really the experts when it comes to cultural humility. But given that it is a very interpersonal dynamic, surveys having to do with clients' perceptions of feeling that they've been treated with respect, with dignity, that they've received the services that they came in looking for, those are all key. Zena, do you want to add anything?
Yeah, and so I'm thinking back to the continuum that we looked at, and part of the conversation that was had there was how cultural proficiency is in kind of on the same level with cultural humility. So looking back at some of those examples that we talked about when we talked about cultural proficiency, so the development and dissemination of promotional materials that are adopted for specific cultural groups. So thinking about those materials that you've developed, that can give you a quantitative measure right there, right? If our brochure, we know that our brochure is available in English, Spanish, Hindi, that would give us a measure of our services that we're providing and being culturally humble to, in this case, the language that our community speaks.
Yeah, and I also think that looking at the framework developed by SAMHSA is really a great one because, again, it's a way that you can almost use the cube as a checkoff box, right? So that you can see for any given priority population that you're serving or that you like to serve, you can think about, okay, what's the level of cultural awareness that is happening for my staff members, my colleagues, that at the individual level, at the programmatic level, and almost at the environmental or organizational level. And then you can go through that process considering cultural knowledge of behavioral health, and cultural skill development, again, for these infinite number of priority populations. And even within these priority populations, we can consider segmentation. So age, geographic location, preferred language, religion, and then thinking about other factors such as what we were discussing earlier about accessibility, so transportation, the time of day of, let's say, service hours, etc. We hope that that answered your question. Keeping in mind that you're always able to use the chat box to ask any more questions. We're going to go through a section that, my apologies, gives us some quick tips on what can be done for our agencies. So one is to make sure that there's a level of involvement among our staff members, our clients or consumers. These quick tips are going to help us to assess at the programmatic and organizational level whether we can consider where our organization is on the continuum that we presented earlier. We can also discuss later how to create and implement culturally appropriate services to diverse populations as you move along the continuum. So we're going to be reviewing these 5 tips that may help guide us to achieve a desired goal as it relates to where we want to be along the continuum. And again, considering that the continuum is a dynamic process that's never really going to have an end point. These 5 tips can also be applied to the culturally responsive framework that we presented, the cube. But please be aware that if an agency seeks a desired outcome, it must be a communal effort throughout the agency. So the 5 tips that are easy to grasp and include are 1, involvement, 2, evaluation, 3, identification, 4, development, and 5, implementation. Let's look at tip number 1. Tip number 1, involvement. Involve your staff in the process. Define those stages of the continuum and provide examples and discuss it amongst yourselves. As an agency, we can all engage our staff members and colleagues to define the stages of the continuum with our own words to gauge understanding and attitudes. You may think of dividing staff into 6 or smaller teams or groups and assign each team a stage on the continuum. As a team, you all can then discuss definitions and have everyone come up with group examples for the assigned stage on the continuum. This can then lend itself to a larger discussion amongst staff that would be helpful for tip number 2. For example, one team might have been assigned cultural destructiveness. As a group, they could have concluded that the Dakota Access Pipeline crossing under the Missouri River and near Standing Rock Indian Reservation could be classified as cultural destructiveness because it poses a threat to clean water and dismantles ancient burial grounds. Now we're going to look at number 2. Evaluation. Evaluate where you are on the continuum. While building on the work done for tip number 1, your staff and your colleagues should be able to agree to where the agency may fall on the continuum. This evaluation can consider internal and external factors and staff members' individual experiences within the agency to make these assessments applicable to your daily work. So an internal assessment might include policies and procedures, screening questions that are being used on your assessment forms, materials, etc., while an external assessment may answer the question, based on what you know and hear, where would the community place you on the continuum? Experiences to consider may include, but are not limited to, interactions with clients, community members, consumers, and fellow agencies. Let's consider, if staff have attained an understanding of the terms stated in the continuum, the next step might be to assess where the agency program fits on that particular continuum. Let's look at tip number 3 now. Identification. After completing your assessment, each team can think about brainstorming to identify needs for tip number 3. While you're identifying your needs, one thing to be mindful of is equity across all organizational programs. For example, your testing center or program may be culturally proficient as it relates to Spanish-speaking Latino MSM, but may be culturally pre-competent as it relates to Black women. Please note that this may require some heavy digging because some changes might be apparent while others might be less evident or obscure. So some things to consider about when you're identifying needs. Your organizational culture and diversity. What are your organization's values? Skills and knowledge. What are the staff skills and knowledge? What are your staff's level of skill or knowledge in a particular area? You may also want to consider the capacity or the resources that are available in relation to communication or technology. And finally, are the materials that you have, whether it's giveaway materials, brochures, or environmental cues that you might have, posters, messaging on your walls, are they meeting the needs of your particular priority population or priority populations? Here are some potential questions to consider. Are your employees skilled and trained to provide culturally appropriate services? Does marketing material from the agency meet the needs of your priority population? Does your agency communicate in a manner that reflects cultural diversity? Are there alternative hours or extended hours for communities that may have religious obligations during your agency's general business hours? Let's take a look now at tip number 4, development. Develop solutions. The next tip after identifying needs is to brainstorm solutions to respond to these needs. As an agency, you can collectively select the top 5 needs or priorities to reach your desired target goal on this particular continuum. Solutions can range from policies to staff training. Ascertain that the solutions will foster an environment that promotes growth, self-reflection, and assessment, as well as effective service delivery. For example, an agency with a priority population of young men who have sex with men, or YMSM, might only train their staff members that identify as YMSM to do testing. However, training all staff members to test may result in the removal of other barriers that may prevent clients from being tested. So part of development of solutions includes the development of internal policies, as well as the ongoing fostering of an environment that is conducive to those policies. For that to be effective and efficient, one needs to show consistency, but at the same time to be flexible and to remain open to suggestions. Now for our final tip, implementation, tip number 5. The implementation of the solutions is a key component to achieving your agency and or programmatic goals. As mentioned previously, training may be part of the solution. Do not hesitate to seek and provide the necessary training, education, and professional development needed to climb the continuum. There is no end to the continuum. Therefore, it requires an ongoing process of engaging with the evolving field. Organizations that practice consistency, flexibility, and open-door policies are better positioned to adjust to changes. Part of implementing solutions might include training, continuing education opportunities, and professional development activities, such as conferences and workshops. We, as Hands United and the larger CPN, are available to provide trainings for your organizations. We can discuss in detail how to request trainings and coaching in the slides ahead. So let's do a quick review. As far as the cultural competence continuum, we want to review what was learned today. There are 6 stages along this continuum: destructiveness, incapacity, blindness, pre competence, competence, and proficiency. There are also 5 tips that can be useful for us as providers to create and implement culturally appropriate and responsive services to diverse populations that include involvement, evaluation, identification, development, and implementation. Let's take a moment now to see if there are any more questions that you might have. One has come in already from Tina Burke. What best strategies you may have that can be utilized to get perhaps your CEO or executive director to understand the importance of having our targeted population represented on staff? That's a great question. One thing that I can tell you right off the bat is that many of us that are capacity building assistance providers, CBAs, have services that you can request related to organizational development and management, ODM, that can aid your organization in including higher or more director level or senior member staff, including the CEOs or executive director, and frontline staff and programmatic level staff to engage in a conversation, develop a strategic plan, and come together to agree upon certain guiding principles or values for your organization when it comes to having your priority population reflected in your staff. Dina, anything to add?
The framework that we use, the cultural competency continuum, comes with recommendations along each stage for organizations to implement. So the examples that we gave as we went through the continuum are the examples that were given within the work that Cross did. And within stage cultural competence and cultural proficiency, that was one of the examples that we gave. And then the second thing I would say is going back to those 5 tips that Gabriella just took us through. Some of those examples that were given were to sit down and define the stages and go through this process as a staff with your team. So define those different stages, provide examples, and discuss it as a team. And that may be a way to go through this activity and engage your CEO or executive director in looking at these stages and defining them. And then moving through the tips, one of the examples was to create some new, do that internal assessment and external assessment. And then identify your needs. And then resulting in step 4, which was developing those internal policies, right? So as going through those tips 1 through 3 as an organization, it may help to highlight to individuals within your organization that some internal policies may need to be updated or changed. For example, hiring staff that's representative of the community.
I completely agree. I also think that the framework here is also something that can be key in guiding this process between different levels of the organization. So those members that are more frontline staff and dealing with clients face-to-face, and having a connection between that and those staff members that are at the more administrative or programmatic level. Again, you'll see at the end of the webinar information where you can request through the CRIS system, SEBA, for this very thing. Any other questions? Or comments? So I'd just like to add that this is a lot of information in a relatively short amount of time. We wanted to give everyone a chance to see these 2 different frameworks side by side. In some ways they really complement each other. In other ways they're very specific to certain theories. But overall, I think the importance is to understand that no matter how we're framing it, whether it's cultural competency, cultural humility, or cultural responsiveness, it is an ongoing process. It does beg us all to be very self-reflective as well as self-aware. And it also really is important to understand that we as individuals are part of an entity, an organization, and that organization we need to ensure that it's a culturally responsive organization. So it's important to have policies, procedures, principles in place that will ensure that our clients are receiving the services that they need and that those services are responsive to their needs, regardless of a staff member's particular attitude or belief or value. Closing up, we wanted to give you again an overview of the services that we at Hands United are offering as far as capacity building assistance. They lie under 3 different components: HIV impact testing, prevention with positives, and organizational development and management, or ODM. We have varied specialties or subtopics that we provide under our components, including HIP or high impact prevention strategies, stigma mapping, community mapping, finding persons living with HIV or finding positives, behavioral health trainings, NTA, cultural humility and responsiveness, of which this webinar is one, targeted testing approaches, linkage and retention and care, behavioral theories, evidence-based interventions or EBIs, engaging priority populations, and using data for program improvement, and much, much more. Here is some information on how to request CEBA. If you are a directly funded organization, you can request CEBA via the CEBA Request Information System, also known as CRIS, and we've provided you with that URL, that link. If you are not funded directly by CDC, you can still get CEBA for free. You just have to contact your health department to help you submit a request. We also here at Hands United can help you do that if you're having a difficult time or you're not sure. But regardless, all CEBA requests must be submitted by using CRIS, and by through the CRIS system, CEBA is free. Just to close up, remember that we're all following each other's journeys. Our differences make us stronger. Our individualities and particularities need to be celebrated, and our collaborative efforts can yield great outcomes. Thank you so much for joining us this afternoon. Look forward to hearing from you, and we hope that you'll take the time to fill out our evaluation. I also want to let all the participants know that the slides will be emailed to you, and that this webinar was recorded and will be archived. The last two slides will provide you with all the references to the frameworks and the information that we provided today, as well as links to most of the information where you can actually download it to look at for free. Thank you.
Thank you.